I'll give you just a couple of quick words about myself. I'd like to thank Naomi and Tom and the team for having me. So I went to medical school at Cornell. I did my residency there and at Sloan Kettering, went to the Cleveland Clinic after that, and I've been taking care of patients with kidney cancer in Philadelphia ever since, the last 20 years. And I think that this is one of the best cities, I must say, to receive care for kidney cancer. There's such depth of expertise here, scientifically, medically, surgically, that I think you can't sort of get better. And I share a lot of patients with my colleagues here, and at Fox Chase we have a really dynamic team, and I really want to thank you. I say that there's two goals that I have of this talk. The first goal is to just say thank you. Frankly, I'm humbled by the fact that every time a patient comes to see me or my team, that they're putting their trust in us. And after just an hour, or maybe even 2 hours, next time they'll see us, they'll be going to sleep, and they'll completely trust that we're going to do and act in their best interest. And I think that's a humbling experience for me and for my team. And the second thing I want to do with this lecture is just teach you a little bit, if I can, make you think a little bit differently about this disease. It's very easy for us to get sort of stuck in our medical terminology, but I'm going to try to make it so that it's understandable, because I know there's a whole spectrum of expertise here that patients have about this disease. Now, hopefully I'm going to use some metaphors to help you understand some of the things we're talking about. So with that, I'll finally say that there's probably no other city in the world where two urologic oncologists both have two Z's in their last name, Uzzo and Guzzo. And we actually both share the same hairstyle, so I'm fortunate to have him as a colleague. All right, so this is for patients, and I just say innovative thinking for locally advanced kidney cancer. Okay, disclosures. We work with drug companies. I'm just going to say that I'm about halfway through my career, 20 years in. I hope it's going to be about 40. And we've more than doubled or tripled life expectancy for kidney cancer in half my career. And a lot of it's because of the collaborations we've had with industry. This doesn't happen without physicians, scientists, industries, and patients allowing us to do these clinical trials. So thank you. So what is locally advanced kidney cancer? I'm going to start just by sort of explaining to you that the kidney is the greatest homeostasis organ we have. By homeostasis, I mean equilibrium. The kidney is responsible for lots of things. And one of the things that we know it's responsible for is filtering the blood. The filtration unit's called the nephron. This is what the nephron looks like. So blood comes into this tuft of blood vessels. It's filtered through this tubular system here, and then the blood returns. But then what the body doesn't want or excretes, the body gets rid of, and there's this exchange in this nephrons. Water in, acid out, potassium in, potassium out. So these are very active, metabolically active cells. They pump things in, they secrete things out. And these metabolically active cells in the proximal tubule need oxygen, they need blood vessels, they need all the things that metabolically active cells need, which means that it's a setup for things like cancer, because that's also what cancer cells need, right? They need more blood vessels, they need more oxygen. So all of this metabolism and disequilibrium that occurs in kidney cancer probably starts here in the proximal tubule of the nephron. That's the cell we think is responsible for most cases of kidney cancer. So once that kidney cancer starts to grow in that nephron, as Dr. Guzzo showed you before, it can get big. It could be as big as a tennis ball, a golf ball, a baseball. We use all these analogies. But then it can start to invade. And it can start to invade the fatty tissue outside the kidney. It can start to invade the fatty tissue inside the kidney. It can start to invade the vessels, the lymph nodes, and the nearby organs. So locally advanced kidney cancer basically means that that cancer is getting out of the capsule, the rind of the kidney, into the fat, into the vein, into the vena cava, and it's starting to progress. It's marching, it's starting to advance, getting into nearby lymph nodes or nearby organs, on the left side the pancreas, on the right side the liver. That's what locally advanced kidney cancer is. We call that increased stage, right? So it's important, though, that you know that there's a difference between clinical stage and pathological stage. A lot of times this is a subtle difference, but people don't recognize it. Clinical stage means what does the CAT scan basically show? Pathological stage means what does it look like under the microscope? So I show here, kidney cancer in the kidney can get out of the capsule and into the nearby fat. Now look at that CAT scan right there. This black stuff is fat. I don't know if the tumor, which is, I'm circling here where the line is, I don't know if the tumor is involving the fat. It's certainly right next to the fat. So I might say that that's stage 2, when in fact it might be stage 3. It might be clinically 2, but pathologically 3. And so that's where we have to have the radiologist help us and the pathologist help us. Here it is invading the vein. Here it is invading the lymph node. And I just want to show you that once you start to look under the microscope, this is cancer, this is fat. The cancer comes up to the fat, but it doesn't go into the fat. I might say that that's stage 2. Here, the cancer is in the fat. This is the fat cells, these big empty blobs. And over here, this is the cancer invading the fat. Now it's stage 3. So your doctor may say you have stage 2, only to find out later you have stage 3. And this is what it looks like when it gets into the vein. This is that vena cava, and that is not only clot, that is also tumor cells in the clot. And under the microscope, here's a tumor inside a vein. So the pathologist has to look for that stuff, and that may change your stage. Same thing here. Here it is in the lymph node. This is all cancer, and this squished part right down here is the normal lymph node, all right? So difference between clinical stage and pathological stage, important distinction. And the reason that that's important is because it shows that the tumor is getting more aggressive, and it shows that the tumor is starting to exit the kidney. And that brings us to this very important concept of micrometastatic disease. Microscopic cells have exited the kidney. I have to say that I always pause when I speak to patients about this, because it's a little bit intuitive, but sometimes you got to just sort of connect the dots. Right? The doctor might say, look, it was contained. I removed it all. The margins were negative. But there's a chance it may come back. And then you say, well, how does that work, right? You just said you got it all. And it's because of microscopic metastases. So microscopic cells can escape what I just showed you into the circulation. And if that happens, we don't know when it happens. We don't know how it happens. We can't measure it. I can't take a blood test to see if there's microscopic cells circulating. But it implies that the tumor at some point is likely to come back. Now sometimes, even though it's circulating in the blood, it might never come back. Why? Because the immune system is able to adapt, correct it, fix it, kill it. But sometimes, a year, 2 years, 5 years later, those microscopic cells will show up on a CAT scan. And that's recurrence. That's recurrence because of that microscopic metastatic disease. And so we talk about when does that microscopic metastasis occur? And basically there's 2 ways to think about this. It's either occurring early or it's occurring late, right? If it occurs late, it means the primary tumor starts here and then it spreads to the lymph nodes in a very orderly, logical fashion, and then it goes to other organs. And you'll see that here. Here's the normal tubular cell of the kidney. Here's where you've got mutations that cause cancer, and more mutations cause it to spread. I like to think, this is a surgeon from 100 years ago named Halsted. That's a very sort of, in our jargon, Halstedian progression. Stage 1 to stage 2, stage 2 to stage 3, to stage 3 to stage 4. Okay? But there's an alternative to that, and that is sometimes it just starts at stage 4. It really never was stage 1 for very long. And if it was really quick. All right? I mean, I don't know if it's days or weeks or months, but it was well before we picked it up. And that means that the tumor got so aggressive so quickly that it became metastatic early on. And we can't detect that. We don't know that. We sometimes knew when somebody comes in with stage 4 disease off the bat. But a question that patients often ask is, how long have I had this? How long has this been there? I'll get to that question in a moment. So the point that I'm trying to make is, if stage 1 becomes stage 2, and then stage 2 becomes stage 3, and then 3 to 4, and the microscopic metastases occur late, then if I remove a stage 1 kidney, I'll cure this, because this will never have happened. And that's what we find most of the time with early kidney cancer. But sometimes that process of circulating tumor cells comes early, and even if I take out the primary, it's coming back. And I've got to watch. And I've got to fight. We've got to fight. And we've got to try to give you some adjuvant therapy, additional therapy to get rid of this. So adjuvant or neoadjuvant therapy is given after surgery, neoadjuvant before surgery. I would consider that the holy grail of surgery, right? I, as a surgeon, would like to remove everything, but if I can't, I've got to ask Dr. Haas, Dr. Plamack, and my colleagues to try to clean up what was left behind, and we didn't know about it. So that's someplace between my incompletely effective surgery, and we don't yet have a cure, as you know, a completely effective cure for kidney cancer. And so we've got to try to figure out where and who to give these therapies to. And I think Dr. Haas is going to talk a little bit more about that in a minute. Because we struggle as clinicians and you as patients. We struggle to advise the right treatment for locally advanced kidney cancer and metastatic disease in the right patient at the right time because we can't measure those microscopic cells. All right, so I'm just going to give you a quick overview. Here's a patient with a large tumor, 71, very healthy. Stage, we're going to call this stage 3 because it looks like it's involving one of the small veins. Should you have the surgery first? Should you get immunotherapy first? Should you go on a clinical trial? We debate that at our meetings. We could sit around on panel sessions and we could all debate that. A lot of that depends upon who you see and where you go first because there are strategies and philosophies that may differ a little bit. But we could disagree on what the right thing to do is in some cases like this. What we know is that if it's stage 3A and the nodes are negative, it's going to be cured about 80% of the time with surgery alone. 20% of the time those microscopic cells will be back. If your lymph node is involved, it's about 40% of the time that that's coming back. How do we stop that from coming back? And unfortunately, I should say fortunately, we now have better therapies. And I said this before, I'm halfway through my career and we've more than tripled life expectancy. Why? It's mostly because the combination of surgery and better therapies. When I was a resident, this is all we had, interferon, right? It wasn't very good. And so what we did is we always took out the kidney because that's as best as we could do. We didn't have good systemic therapies. But now there's a whole panoply of new therapies. I mean, a decade worth of new therapies for kidney cancer, and it really spills over to lung cancer and breast cancer and all other sorts of cancers. The research, I'm sure most people are aware, Bill Kaelin recently won the Nobel Prize in medicine recently for his sentinel work in kidney cancer, and all of that means for other cancers as well. So we have a lot of options, and that means we have to start to think strategically. Surgery is often perceived as playing offense. Systemic therapy is often thought of as playing defense. And I want to tell you as patients, you should rethink that a little bit. They're both offense, all right? Surgery and systemic therapy is both offense. So why do we take out a kidney tumor if we think it's locally advanced? Why do we take out a kidney tumor if we think it's metastatic? Because we want to get rid of as much of it or debulk it, get rid of as much of those bad clones as possible. And that may actually help, in some cases, the systemic therapy work better. And we debate this. It's complicated, but I just want you to understand there are some times where removing it in the setting of metastasis is still the right thing to do, but we really have to start to think strategically. And there are some clinical trials that guide us. So it's aggressive therapy surgically, but please think of surgery and systemic therapy both as being offensive, if you go with my metaphor. The guidelines, the NCCN guidelines, which Fox Chase has been involved with for many, many years, really still give the clinician a lot of leeway as to what to do if you've taken out a stage 3 kidney cancer or taken out the lymph nodes and you want to try to sort of give them systemic therapies or additional cures. We don't have all the answers, and I'm putting this here mostly to acknowledge the fact that clinicians and opinions may differ because there's no clear answer yet. But I start to think of this very strategically, and I'm going to use this metaphor here for a minute, and that is this idea that cancer is an ecosystem. And I'm going to explain to you what I mean when I say that. An ecosystem is kind of like a pond, and in this pond you've got lots of bacteria, and those bacteria are struggling for nutrients, and they're struggling against each other. Who's going to live? Who's going to die? It's survival of the fittest, right? And so at one point, somebody comes and dumps some chemicals in that pond. Some bacteria is resistant to it. Other bacteria die because of it. So you get this selection of the bacteria that are resistant to that treatment. And suddenly, you start to get this whole ecosystem in this pond, and one bacteria emerges as a super virulent or really killer bacteria. That's kind of like what cancer is. We have this whole collection of cells. We'll call them clones. And they have different mutations, and they have different responses. In one patient, we have all these different mutations. And so that's what kidney cancer is in every person who has it. And that's, in fact, what cancer is in every person that has it. And I can tell you some of the data. This is from a couple of years back, about 6 years ago, where they took one person, one single patient. They biopsied his kidney cancer in multiple places, biopsied his metastasis in multiple places, and looked at the mutations. And if you just look here, Where those blue dots are, those are all unique mutations in different parts of the primary tumor and unique mutations, different part of metastases, meaning that these are all different clones. In my analogy, all different bacteria in that pond fighting for survival of the fittest. All right? I'm not going to go through too much of this really landmark article. This is a great article published in really Cell, which is the best scientific magazine, I think, by all accounts. And what these researchers in England did is they showed that the foundation for this sort of clones, these sort of survival of the fittest in kidney cancer, occurs when you've got a mutation in the third chromosome, the short arm of the third chromosome, 3p. And it probably occurs decades before kidney cancer emerges. And that is as unsettling as it comes. If you're 60 years old and you've got a diagnosis of kidney cancer, the natural thought is, this must have just occurred, right? Something happened last year, last month, 2 years ago. It probably happened as a genetic event a decade or more ago, and we just didn't know it. That's unsettling for me, as unsettling for me as it is for you. But that's what the science is starting to tell us. So what happens is you've got these mutations occurring when you're 30 and 40 for reasons that are unclear. You've got these cells that are sort of trying to fight each other, and then you have this randomness where some of them are living and some of them are dying, and maybe it's related to sort of environmental exposures, and maybe it's related to your immune system. And then there's this long period of latency where the cells are just sort of sitting there and you can't detect them until they finally, one clone emerges as the bad one. And as one clone emerges as the bad one, then we see it. We start to give immunotherapy and targeted therapy, and we start to kill some of them, but we're not fully successful yet. And ultimately, this results in advanced disease. And that's sort of the battle that we're all fighting when it comes to cancer. It's a different way of thinking about it. And so we can start to talk about what the various good clones look like, if there's such a thing as a slow-growing cancer cell, and what the bad clones look like. And the scientists have really done yeoman's work on trying to figure out what these things look like and how we could attack each of them. But there's this concept, and I'm going to sort of almost end up with this sort of one concept. And I sort of alluded to it before about those bacteria in that pond. The bad ones emerge. The bad ones are usually very quick growing, very easily mutated, and there's really only one or two different types of them. They've already killed all the other ones off, right? So we talk about heterogeneity. That means, are there lots of clones? And we talk about instability, genomic instability. Are they really mutating quickly? So the worst situation, I'm going to just flip through right here, is if there's not a lot of clones and they're mutating quickly. That means the bad ones are really winning. And I use this usually in one of my talks for physicians. But somebody once told me when I went to business school that if I can't explain something to my daughter, who's 16, then I'm probably not going to be able to, then I probably don't really fully understand it. So I'm going to try to explain this to you like I would explain it to my 16-year-old daughter. And in fact, I went through this exercise with her, and I said to her, this is what I'm trying to get across about a year ago. And we were talking about sort of Darwin and the origin of species and the whole idea of like evolution. And she said, Dad, that's sort of like the minions, right? So what happens? The minions are mutated humans, just like a kidney cancer cell, right? Those mutated humans, actually, they sort of sit there and they're kind of friendly, but they shouldn't be there, right? But what happens along the line is, this agent that this mad scientist, I forgot his name, sort of injects, it's PX41 or something like this. He somehow mutates these people into really bad clones. And so this sort of idea of clonal progression for kidney cancer means that here, if you've got a lot of good clones here, they're all kind of friendly minions, there's not variety, that's not a bad cancer. You could probably, if you're 80 years old, watch a cancer like that. But if you've got a lot of bad clones, and there's a lot of them, there's no yellow, it's all purple, because that's all the bad clones, that's the guy that's going to get you, all right? That's the one we've got to watch for. And if we can find that cancer, then maybe we've got a better shot. And then, of course, there's a whole sort of spectrum between the good guys are winning and the bad guys are winning. But by and large, I want you to think of cancer as this struggle, this battle between good clones, if I can say good, bad clones, and your immune system. And it is survival of the fittest of those clones. My job, Dr. Haas and Dr. Plumek's job, is to help you win. In the end, how do we figure out who to operate on with locally advanced kidney cancer? Well, biology is king, right? Sometimes we just really can't explain why this happened, or even sometimes how it happened. We know the genetic events, but unfortunately, we've got to deal with the biology that is occurring in any one of our bodies. Selection is queen. We've got to pick the right person for the right operation on the right day. And that means that healthier, younger people generally tend to do better with surgery than older, sicker people. Same thing, as you can imagine, with immunotherapy. And we've got lots of curves like this to show that the healthier and the stronger you are when you're getting your therapy, the more likely you are to succeed. All right? We've also got lots of calculators, and we use this stuff at Fox Chase all the time. We belong to the National Surgical Quality Program. It's a national program called NSQIP, where we submit our data every 6 months, and we look at the complications that we have, and we compare them to the complications across the country. And I'm proud to say we consistently rank in the top 10% nationally for our surgical quality. And the therapies that we give you are the prince and the princess who occasionally try to usurp the throne. Biology is king, selection is queen, and then we have to try to intervene to beat the king or the queen, right? But sometimes we can't do it. And that's what we struggle with every day. And that's what you trust us to do in your best interest. So how do we do this? How do we figure out what the right thing to do is? Well, we know that we don't know it all. And so in situations where we're uncertain, we have to try our best to guide you to make a good choice. So we should try to simplify those choices as best as we can, frame the decisions as best as we can, and estimate probabilities so you can make trade-offs and make a good informed choice. What does that mean? As I said before, if you've got metastatic kidney cancer, whether you have surgery first or whether you have immunotherapy first is still a source of some debate. But a lot of this reflects the doctors that you see. And I think you can't go wrong in the city of Philadelphia. If you've got effective systemic therapy, and we've got good data to show that that should be the first step, then you'll often get systemic therapy first or be put on a clinical trial. And I must say, a clinical trial has been the force that has moved this situation forward. I don't use the term clinical trial lightly because I know it suggests to patients that it's an experimentation, especially if it's a placebo. But it really has pushed this field forward like none other. And of course, if you come to a surgeon, we might just sort of say, well, look, we can have competing data and different ideas, but it's the combination that's going to work. Should it be surgery first or immunotherapy first or surgery? I think that's the question that we have to help you make the decision for. So I struggle less now that we have good systemic therapy to choose the right patient and to do the right operation at the right time. I think perioperative treatment will cure more patients with kidney cancer in my lifetime. I'm confident of that. And selection for those patients will become easier. Thank you very much.